Thank you so much, Harry, and Peggy and Francis. It's a real pleasure to get to join you all this morning. I always enjoy the chance to work with Francis and Peggy, two leaders whom I admire immensely and from whom I've learned a great deal about not just the topics at hand this morning, but about leadership overall. I guess I'm the cleanup hitter here, or maybe the downfield receiver. My job is to think about the kind of knowledge and integrity that Peggy and Francis and their agencies bring to the world of making suffering decrease and make the suffering decrease by putting good care into the experience of over 100 million people that depend on CMS and our work, the beneficiaries of Medicare, Medicaid, CHIP, and now with the merger of the new Office of Consumer Information and Insurance Oversight into CMS, the 30 million people that will eventually benefit from the setting up of the systems of exchange, which will allow people who are having trouble finding insurance to get that insurance. It's a daunting task, very inspiring to me, and I love working at CMS and getting to work with the people there. Our job is translation, is to take knowledge and reduce suffering. The context we're in is very fraught. The healthcare system in its current form is unsustainable. We've had an immense win in our country, I think, in the past years. The Affordable Care Act has come into place, and we are really moving apace toward finally offering tens of millions of people in our country the security of being able to wake up in the morning knowing that they're not going to lose their health insurance, they're not going to go bankrupt from health care costs. That's a tremendous win. But it won't be sustainable. It won't be a win for the long haul unless health care itself improves. I could spend the entire 20 minutes I have going through the symptoms. That is what it is that needs to be better, but I'm sure you in the room know as much as I do about it. In the arena of patient safety, something very important to me right now because we've just launched a partnership for patients which is oriented around safety. We have major problems. The Health Affairs, the journal Health Affairs just 2 weeks ago carried an article by Dave Klassen and his colleagues showing that injury rates to patients in American hospitals occur at the rate of 1 in 3 admissions. About one third of patients are measurably injured by the care they receive in hospitals. And the vast majority of that kind of injury from care turns out to be preventable if we can get serious about it as a country, and we will. There are many other forms of shortfall in health care around reliability of care, the delivery to people with absolute reliability of the benefits of the science and breakthroughs that Francis and Peggy and their colleagues produce for us every day. On the financial side, we have trouble. The Medicare Trust Fund has been extended, its life extended by the Affordable Care Act a lot, but it is in the long term in jeopardy. Medicaid costs are currently a quarter of state budgets, and states are writhing under deficits today. And if you go to the payer side, employers and their employees, you find the weight of healthcare costs really being quite a burden on our economy. It's become more urgent. If you heard the President's speech last week, you got that sense of urgency. We don't have the luxury anymore, if we ever had it, of waiting a long time to have healthcare become the sustainable, high-quality system we need. What's this leading to is a sort of national choice. It appears to overstate it a bit that the country is at a cusp. Two strategies face us. One is cutting things. When the budget's in trouble, you cut the budget. You take things away, try to do less, restrict. And there are lots of proposals out there to take things away from Medicare and Medicaid beneficiaries because we have to solve the cost problem. It's not sustainable for our country. That's the obvious solution. It's just the wrong one. The second option, from my viewpoint, I would propose, is to change the way you do your work. When the budget's tough and resources aren't available, an inventive, optimistic, entrepreneurial nation or organization figures out a better way to do it. I think that is a real choice between cutting and improving. And I think the right choice is improving. I'm not in favor of cutting. I'm in favor of changing. Lowering costs for our country and for patients and families by withholding care is bad. It's bad for patients, bad for our future. It's bad for business and bad for the nation. It is unnecessary if we can invent our way to solution, and I think we can. What Americans want, what we all want, what our country needs, we call, and now CMS, the three-part aim. That's the terminology I brought in there. The three-part aim is clear: better health, upstream from the causes of illness, better health care, safer, more effective, more patient-centered, timelier, more efficient, more effective, and lower cost, but lower cost achieved through improvement of care, and that's the trick. Better care, better health, and lower cost through improvement. The foundation for that kind of change, if we do it properly, is science. It's knowledge, not guesswork, not rolling dice, but using knowledge to change the way we try to relieve suffering. I believe the opportunities and possibilities are more than up to the task of the magnitude of challenges, but will it take a kind of coming together as a country, a kind of agreement, all of us together, that that's the job, to change care, to make it the care we want and need. I think every morning about 100 million beneficiaries, but actually we couldn't make the improvement for Medicare and Medicaid without the whole system changing. There's no way to parse out the Medicare and Medicaid system, so we really are talking about the improvement of care in the nation. That will be very difficult. It's difficult because change is always hard. It's difficult because the status quo legacy environment is not particularly friendly to the kinds of improvements we need. I'll give you a few examples. The biggest enemy, the true enemy of improvement, is fragmentation. It's when each separate component of a system that's highly interdependent suboptimizes itself that you get suboptimal performance, and that's where we are. And that comes out of legacy systems like the payment systems. The payment systems are highly fragmented. Providers are paid piece by piece, within discipline, within institution, not across the time and space, the journeys that patients actually take. They're paid for doing more rather than for doing better. We have a volume-based payment system instead of one that says, I don't really want to pay you for how much you do. I want to pay you for how well you do, or for how well the patient does. The consequences of that payment system, and also the training systems and the sociology and institutional substructures, the legacy of that is failure to coordinate, and that's kind of the 800-pound gorilla. It has to do with whether care is coordinated, seamless, and patient-centered, especially for those people in our neighbors and some of ourselves who take the most care, the chronically ill, the people who really bear a lot of burden and who need help through journeys. They don't experience health and healthcare as an event. They experience it as a journey across time and space. We don't do very well for those journeys today. The evidence is very strong for that. It's reflected in the patient's experience as they have to tell their story over and over again to every doctor they meet. It's the lost laboratory test, the redundant procedure, the deterioration that occurs out of visual fields as a chronically ill patient goes home from the hospital, deteriorates, and comes back into the hospital. It's in the deficiency of primary care and primary care supports for people where they want to be, in their homes instead of in our institutions. There are gaps in skills because we haven't valued coordination and seamlessness of care. We haven't trained ourselves and our colleague professionals to improve care over time and space. There are examples of success, abundantly so. Within the sciences of healthcare delivery, we now have surfaced models and proven models which overcome everything I just told you about: patient safety issues, issues of seamless and coordinated care, issues of efficiency, strengthening primary care and communication, putting care in the hands of patients themselves so they can be where they want to be and take care of themselves. We have science behind that. The spread of that knowledge, just as the spread of some of the biotechnologies Francis and Peggy have talked about, has been slow. That has been acceptable, I suppose, if lamentable, in the prior era. But under the kind of stress we have now, this choice between cutting and improving, tempo now is everything. I think the luxury of delay is no longer really available to us, not if we want a country and a healthcare system that performs as it best can, given the available knowledge and the knowledge we can get. We have accepted as inevitable that good practices, best models, take years and years, decades sometimes, to become the norm, if they ever do. I think that luxury should be now regarded as no longer available. In any other industry, the pace we're familiar at in healthcare in adopting productive and responsive, socially responsive innovations would be a formula for going out of business. If a computer company moved at the pace of healthcare, it would die within a year in the global economic environment. what you see in the computer world, for example, as a consequence of that dynamic is incredibly fast improvement compared to healthcare. Although Francis is able to show improvements in technology, the sequencing of genomes, overall for the improvement of healthcare, it looks nothing like the pace of improvement of products and services in other industries. That's what we have to change. Tempo is everything. We have to be vigilant about not spreading bad practices, though, because those can spread at the same tempo as good ones, but we ought to be smart enough to be able to do that sorting. When I came to CMS now 9 months ago, I conceived of that agency, as many did within. We have 4,500 employees, and not one really disagrees with this, that we're not just a payer by any means. We're stewards of the well-being of 100 million people, and in some sense, partners in the progression of the entire healthcare system. Harry mentioned the mission statement of CMS, which is, since I've been there, the following. The CMS is a major force and a trustworthy partner for the continual improvement of health and healthcare for all Americans. A major force, proactive, a trustworthy partner. We are going to do this together with other agencies and with the private sector. For the continual improvement, good enough isn't good enough. The concept is wherever we are, we ought to be better. Of health and healthcare is a change in our self-image, not just care, but providing health. And for all Americans is what I said before. It would be illogical to focus only on the Medicare and Medicaid beneficiary. It's a total systemic issue. There's very good news. The good news is that there is innovation in healthcare all the way along the pipeline, from the biomedicine Francis has mastered to the delivery, to the regulatory science that Peggy's championing, to the delivery system sciences now to figure out how care can be configured. And even now, early but important in this, what I would call the science of spread, which is understanding how something good goes to scale. I could recite for you stories of hospitals and clinics and integrated systems all over the United States that really are breaking through to new levels of performance. We know what to do. Now we need to do it everywhere. A good example of that investment in the Affordable Care Act and leadership we're seeing now in this administration is the Partnership for Patients that was launched 2 weeks ago by Secretary Sebelius and me. This is a challenge to the country. One area of knowledge that we have is how care can be safe. That 1 out of 3 injuries in hospitals is avoidable. We know how to do it. I've gotten an email from a hospital that's gone 5 years without a central line bacteremia case, 2 years without a ventilator pneumonia, hospitals that have cut surgical site infections by 60% in 2 years. We have examples of tremendous progress with respect to safety. Reduction of readmission rates by 60% in a safety net system hospital in Texas in the past 2 years. We know what to do. The problem is that excellence is not the norm. We haven't brought excellence to scale. And the Partnership for Patients is a national effort, public and private entities together, trying to spread what we know about patient safety to every single hospital, because it's hospital focused at the moment, all over the country. By the end of 2013, we're aiming for a 40% reduction in hospital-acquired conditions, complications like avoidable pulmonary emboli, pressure ulcers, ventilator pneumonias, surgical site infections, methicillin-resistant staph infections, and so on. A 40% reduction compared to now, and a 20% reduction in unnecessary readmissions. Easily accessible goals if we're willing to really try hard to change and make excellence the norm. That's only one example, this area of patient safety. I could go into that if I had time for every other dimension of performance in the healthcare system where we commit to excellence as the norm. We have resources now. The Affordable Care Act has placed at the country's disposal a series of resources that kind of complete the suite, from the upstream science that Francis produces to the regulatory science that Peggy now understands and leads in, to the implementation science I'm talking about. We have, importantly, the new Innovation Center, the Center for Medicare and Medicaid Innovation, funded by Congress at $10 billion over this next 10 years, that can focus on better patient care, safer care, more seamless care, models all over the country of better chronic disease care, and community and population health and prevention. The strategies of the Innovation Center are being formulated as we speak. I hope within the next month or so we will have even more requests for proposals coming out of that center, or at least in the chute and ready to reach prime time this summer and fall. I'm very excited about the potential of that center. That center is also working very closely on a particular focused issue of translation, I guess, to take the theme here, and that has to do with dual eligibles. There are 9.1 million people in our country who happen to be eligible for Medicare and Medicaid both, 9.1 million. They take about $350 billion of expenditure, and they're our most vulnerable neighbors. They're people who, they're eligible for Medicare and Medicaid because they have quite a burden of multiple chronic illness, poverty, behavioral health issues, extremely costly, extremely needy, and at the moment being let down. These duals are not in the kind of coordinated, seamless care that they need. Congress established the Office of Federally Coordinated Health Care, the duals office is what I would call it, and its job is to finally get these extremely vulnerable people into the kind of care systems that can keep them healthy at home without bouncing in and out of hospitals, living longer and fuller lives, and saving us all and them money because their expenses are largely related to deficiencies and defects in their care. In this pursuit of swinging the bat the whole way from knowledge to implementation, we couldn't have better partners than NIH and FDA. And as Francis and Peggy know, we're getting very strong signals from the Secretary and the administration as a whole that they expect us to be partners. It's really thrilling to experience this encouragement to coordinate and see ourselves as citizens in the same system. With NIH, as Francis mentioned, we're taking lessons from the Leadership Council that NIH formed with FDA. Francis came to me with the idea of using that as a template, and now we have such an ongoing effort between NIH and CMS. We have 4 working parties at the moment working on speed of translation, understanding what the world of genomics will face CMS with in terms of coverage and policy decisions in the next few years. Francis mentioned the imminent issue of helical CT screening and taking the diabetes prevention trial, immensely successful program, to full scale. Those are examples where I guess I think of it as a short circuit system. Could we create a short circuit between that kind of knowledge generation and the needs of our beneficiaries? It goes the other way. Our beneficiaries in our system can be helpful to the knowledge generation process, and so one of the working issues is how could we make the CMS data more useful to the upstream discovery processes that Francis has stewardship of, with absolutely full recognition of the need to protect patient privacy at the same time. Equally, we're partnering more and more with the FDA. We have many conversations. Our concerns often overlap a lot. We've looked recently and will continue to at simultaneous review processes that will speed our shared work. So there's good news and there's bad news. The bad news is we've got some trouble. We are not at the system for better care, better health, and lower costs, not at the level the country needs, not at the level that we can turn over better care, not just to current beneficiaries, but to future generations. We have challenges, but there's really great news. We have unprecedented knowledge. We understand more than we ever have before about what delivery system science ought to be and look like. We have the upstream supply of innovations and change that it's thrilling to consider what would be possible for our nation if we create that short circuit to execution. We have examples all over the country of success that our job now in CMS is to build on and bring to full scale, making excellence the norm. Thank you.